I'm very much indebted to the panel. I want to invite Donna Lynn to come up because we're going to have the panel discussion. And I want to say something about what I learned as I listened to my colleagues. I learned that there can be cardiac, pulmonary, or other whole body impacts, and that there are treatments, but our awareness has to be there. So I learned that, and I learned that we have to communicate to our professionals. What I learned here is that there can be lots of psychosocial and psycho-emotional effects that go along with cancer diagnosis and treatment, and that uncertainty, fear, depression are all vulnerabilities a person may face, but that we need to let our professionals know, again, the theme of communication, so that we can then get some of the supports that we need. I learned again, was reminded again, that there are lots of intimacy and sexuality-related issues that can surface, and that the inability to discuss them is truly problematic between the partners in the relationship and between the healthcare provider and the persons going through the cancer experiences, and that, again, communication looms as a really, really important issue. I learned that spirituality and religion are not one and the same, and that the whole meaningfulness of our lives that sometimes gets thrown into chaos and that we question during the time of the cancer diagnosis and treatment are things that we need to feel entitled to feel and to express, and to find those who can talk about them with us so that we have some solace from those feelings that get kicked up from us. And again, communication proves terribly important. And I learned that we haven't forgotten that there are some very bottom line issues that have to do with survival financially, having the comfort of health insurance, knowing that you can get the right decisions made on your behalf from your employer. And again, communication looms because it's so important to let people know what it is that you might need in order to make work more possible for you. And so one running theme that I heard, and for which I feel very appreciative of my colleagues, is on every single one of these important domains that we've chosen to focus on tonight, the communication, the ability to tell people what we need, to persevere on our own behalf, is such an important piece of the survivorship puzzle that we're looking to put together for ourselves. And so now it's your turn. We bring Donna Lynn back to round out the panel so that we can have a dialogue about what do we need to seek from those empowered in New Jersey to help us bring survivorship more and more forward from the point of view of understanding what people really are feeling and what they're really needing. And we're going to take some notes on what you say because we know that there's more that we need to do to understand survivorship and to care for your survivorship needs in New Jersey. We have the New Jersey Commission on Cancer Research. So research, where do we need to go? What are the things that we need to better understand from your point of view? We can read the books and read all of the studies that have been done. From your point of view, what do we need to better understand on your behalf? We have certainly the CINJ, and we have the hospitals in New Jersey, the partners, the affiliates, who all want to do the right thing clinically and deal with each of these domains on behalf of survivors. What do we need to do? Because the Institute of Medicine said it very clearly when they titled their document. They called it Lost in Transition, from cancer patient to cancer survivor. That wasn't a just happenstance kind of title. You can be sure it really was meant to reflect that the transition has not been made easy for people. So let me see where the bravery in the room is. Yeah. Because that's what it always takes to be the first speaker. Oh, to remember, if you're coming to the microphone, thank you. I'm getting hand signals here. To remember, if you're coming to the microphone, that we do need you to sign a release, since this will be on YouTube or some other vehicle that's out there, hopefully not like the rest of the YouTube things that are out there. I see a question at the back of the room, and let me just ask you first, if the person is choosing not to be on camera, do they still need to sign a paper? Okay, if you choose not to be on camera, you don't need to sign a paper. But if you are going to come to camera, which means come to the microphone, and you You have walking mics. So if you agree to sign a paper, then by all means, Mike, could you just keep going further, further, further? Got it. Thank you for being first.
Oh, is this on? Okay. I guess as a cancer patient, sometimes it just becomes habit. I have been battling CML for 8.5 years. I have what my doctors at Hopkins call a difficult case because no matter what they've done, no remission and the roller coaster numbers, which for those of you who work with cancer, as you know, numbers are everything. My question is for Barbara. Because of my treatment and my illness, I was forced to leave work. I was working as a personal trainer, and I started on interferon therapy, and my doctor just felt that dropping weights on someone's head wasn't going to be a good idea. I have not been back to work since about 6 months after my diagnosis. What are my rights going back into the workplace as far as insurance benefits, insurance of any kind, employer equality, and where do I fall?
Yeah, that's a very good question. The question is, once you've been diagnosed and then you've missed work for a substantial period of time, I guess in your case about 6 years, then how do you reintegrate back into the workplace? You have the right to be treated based on your ability to do the job you're interviewing for. So when you go back to work, you want to, even though you may be thinking about cancer every day because it's affecting you every day, you want to place the focus on why are you looking for that job? Why are you the best person for that job? Do you have the qualifications they're looking for? Do you have the education they're looking for, the experience they're looking for? And keep the focus on that because they're not as concerned with your health. They're concerned with can you do what that job entails. So you need to practice the interviewing skills based on why focus on going forward. You don't need to bring to an interview first any personal information about you. Employers don't have the right to know everything about your medical health. They only have the right to know, are you able to do the job you're applying for? Now, if there's something in particular about the treatment you're going through or the consequences of the treatment that you think would affect your ability to do that job, then you could raise it as a possible accommodation. But the most important thing is first to try to get the job based solely on your qualifications for the work and not any discussion about your cancer treatment at all. Another reason for doing that is many times if you've had cancer and you're going back to work, obviously you're going back because you want to reintegrate into the working environment and for the social aspect of it, the financial aspect of it. But usually number one is you want a really good health plan. And you're entitled to the same health plan that everyone else in that job in the same company has. It is possible that it's likely they can impose pre-existing conditions. And that is one of the biggest catches right now for cancer survivors is dealing with the pre-existing conditions. But when you interview for the job, you don't want them to think you're looking for the job because you want the health plan. Wait until you get an offer for somebody, and then you can say, by the way, may I see your benefits package? So you can figure out, is that plan going to be good enough for you, or then you need to look elsewhere. And finally, if you have a really big gap, you have a pretty significant gap in your resume, sometimes there's no law that says your resume has to look like the resume they taught you to do when you were graduating from high school or college. It does not have to go year by year by year and then have this screaming hole in the middle so that you feel like you've got to explain what you weren't doing. You can organize your resume by job skills or by other kinds of experiences in a way that's not just that raw chronology. And you can also say you took time off for personal needs or health needs without going into any specific details. Because if you say you were in cancer treatment, or say you're still in cancer treatment, you don't know what kind of impact that's going to have on the individual. They may have all sorts of, we talked about myths at the beginning of the night. They may have a lot of myths about what that means. So present yourself as you're the right person for the job because you have the skills and the background to do it.
Thank you, Barbara. It also occurs to me, I should say, that, I wonder when I put my research hat on, do we really understand the subgroup issues that you're speaking about as well as we should? Is there, I'm always wondering when I hear a very important personal question like the one you just asked, is there a broader research issue that we need to continue to think about also for this special subpopulation? So thank you for bringing that up. Sorry, did I stop you from saying something? Okay. Thank you. Thank you for asking. And we have a question, yes. Are you willing to come to the microphone? We would dearly love if you come up to the microphone, because you see, it is you who choose to come up to the microphone who will make this the most real for the people who are just going to be watching it on YouTube or wherever that is. Ned, say something better than I say. What is it really going on? Not YouTube like we understand YouTube.
Yes.
Oh, it's going on YouTube just like we understand YouTube to be. I stand corrected.
There are a number of places where this is apt to go. We have a university arrangement with Apple Computer called iTunes University. And so those of you who know about iTunes, is you can go on and download the video or the audio onto your iPod or your desktop and view it. We do have, believe it or not, in conjunction with the Cancer Commission, an iTunes or a YouTube site. They have a new series of YouTube sites for nonprofit organizations, and we have all of the videos from last year's Unmet Needs program and other scientific programs. And if you search for Cancer in New Jersey on YouTube, it will take you to that. Also takes you to a lot of other interesting places. Okay. And finally, this will be put in the form of a DVD and a written report, as again, the Cancer Commission and others have done for last year's Unmet Needs. That will be distributed to all of the partners and other people to pass on to patients. I know we have a number of copies of last year's Unmet Needs program up in our library at CINJ, and we're trying to get the most dispersion of the information. So it's going to be everywhere.
Okay. So I invite you to share your question.
Okay, great.
Close to the microphone with your mouth, okay?
Well, I want to say, first of all, thank you for providing us with such a forum. My name is Deborah. I am a breast cancer survivor. September, I will celebrate 4 years of survivorship. Breast cancer, I'm hoping that this is the right forum to ask this question. I came in a little late, and I'm hearing, basically, you're talking a lot about the workplace and how it's adapts or should adapt to people going through treatment and cancer. I have a question about the responsibility of the medical professionals that we come to for help. I have a dear friend who took her last breath on Sunday, and she has been in the battle of breast cancer for many years. And I was very surprised to learn about her situation, that she had come to seek help from her medical professional from a place like CINJ, if not CINJ, for assistance, because at the end she was having a lot of trouble with walking. And the end came very quickly. I think she came to the hospital maybe for no more than a week, maybe 2 weeks. The last time I saw her, she looked well, but I know that she was going through the struggles of trying to survive and prolong her life. I want to get to the point with, I'm just trying to figure out, like, what's in the mindset of the health professional when someone comes to you, they're clearly at the end stages. They're a mother, they have children, they have a spouse, they contributed significantly to their community, they were a career woman who once worked for the state up until they were too sick to continue with their work schedule. Why would a health professional deny them if they come to them for help, for needing some type of tool or resource to help them get along their day-to-day, to help them endure their quality of life?
Clearly, I first want to address the fact that you have gone through what has to have been a very painful period for you in your own resonating to your friend's circumstance. So I first want to acknowledge that and say that I'm sorry that that's so.
Thank you.
We all are committed to care. And I wish I could say that every day of the week, we all wake up and understand our patients' needs with perfection and follow through with excellence. I know that I have not done 100% of what I think I'm capable of every single day of my life. So while I can't speak for another professional and I can't speak for this circumstance, I know that speaking for myself, I try to understand what the person is coming forward needing and to respond within the framework of what I can possibly provide. And I'm sorry that that doesn't feel that that is what happened for your friend. Let me ask, I don't want to supersede if anybody on the panel feels they needed to respond. I just felt like I needed to respond with a general answer, since we'll never know, we weren't in the specifics of what happened for your friend. I truly am feeling what you're asking.
So like, it's just an individual situation, basically. I mean, when I think of it, I can't conceive like why, you would get a no. I tried to say, well, maybe they knew the person was terminal any minute. But still, isn't that something that could have possibly helped the person to exit maybe more, I don't know, feeling just a little more, having a little more integrity? So maybe I'm bringing this up so that this could be at the forefront of the panel's minds and you can share this with your colleagues. And so that, there are people suffering for something basic and simple, if they can get it, if you can give it. Thank you.
I hear. I hear. May I? Yes. Yes. I see the person right here next to a person with a fan. Do you want to come up for us so that we can then people know that there are real people here with us tonight, not just those of us sitting up here.
Just something hit me with Deborah's story. I think I have the utmost appreciation and respect for what you're all providing us here. But then it seems to me a little conspicuous by its absence that I think there are no medical professionals, there are no doctors, oncologists, whatever. You all referred to like healthcare providers, and the need for communication. How do our needs here get communicated to the medical profession when they're not represented here? And I don't know if that speaks to what Deborah's friend was denied or not. I'm not quite sure what her, personal request was at that point, but how do we communicate with the doctors when they're not here?
We're in the audience. We're here listening.
Okay.
Yes.
Okay.
Dr. Todd, Dr. Gable, and I may be missing others who are here as well. As we chose to let the group of professionals who are the hands-on providers in each of these special domains, and so that's why we chose Dr. Cunningham, who is the chief of all of nursing here, to speak to the physical and so on and so forth. But our physician colleagues are here. And I would say to you, speaking for myself and speaking for the CINJ folks, are very present with us. When we talk about interdisciplinary teams in the current era, in the old days, people used to talk about multidisciplinary teams, which there is a shade of distinction. Multi just means a whole lot of people are involved. Interdisciplinary means those people are all working together, all of them. So the whole interdisciplinary team is very, very much alive here at CINJ, and I can speak for several other institutions that I know intimately in the state, thank goodness, as well.
Okay.
Can I say something?
Yes, of course.
Yeah, I'd like to say something to Deborah. Where is she? Okay. As a pediatric nurse, I before speaking about that, I'd first like to convey how sorry I am about your friend's loss, and doubly sorry for the negative experience that she faced. I think end-of-life care, I think in what you related to your situation or your friend's situation is very contingent upon circumstances. And I think end-of-life care across the board, it's always in the New York Times. There's a need for improvement in how we address end-of-life care and palliative care in the United States. But I also think that I think there are circumstances, and I don't know the circumstance, but when someone comes into a healthcare setting not familiar with healthcare professionals, sometimes it's very, very difficult to get great care. So I think that in lots of times there's extenuating circumstances. But I remember a number of years ago, I remember reading in the New York Times, and it came from Boston Children's Hospital, how the end-of-life care for children in the United States was not what it should be. And I remember taking offense to that because I spent the first 9 years of my clinical practice as a nurse in I'm dating myself now, in the late 1970s and 1980s, caring for children with cancer. And at that point, most of them died. And I really felt very honored to be with people at that point of their life, to help family members get at closure. But I also will comment on the effect it had on me. It was extremely difficult, extremely depleting of energy. I mourned with every one of those children. I have reminders in my house of every single one of those children. So I think that in response, I don't know the circumstances to what your friend encountered or where she was in the healthcare system. But I think so much of it is advocacy. I think that you need to have relationships with your physicians, with your oncologists, with your nurses, with your social workers. And really that comprehensive care really makes an important difference. Maybe not all the times, but it's what we should optimally strive for in getting good health care.
And I just wanted to say one other thing, too. Thank you so much. I think Kathy did a wonderful job about talking about end-of-life care. And I don't know anything about your situation, but you honored your friend. Mm-hmm. You honored her in a profound way. I think everybody in this room received what you said and were stunned for your loss. But you were brave, and you honored her. And just to say finally that we have a long way to go with end-of-life care. As Kathy was saying, it's improving all the time, but I see things that could be better every day, and not through the fault. People are trying to do better, but we still have not gotten where we need to be. So I just wanted to say thank you.
I just wanted to add one more thing to that. I mean, this is the whole point of the cancer survivorship movement for the last several decades. This communication and advocacy is a two-way street. I mean, we need to empower survivors and about how to express your needs, and that's at all stages of cancer. Just from the day you're diagnosed to several years in or out of remission to the last stages of care for those who have end-of-life issues. But to ask for the services so that you express what your needs are and know that you're entitled to try to have those needs met. But it's also to empower the providers, and that includes not only the physicians, but oncology nurses, oncology social workers, therapists, spiritual therapists, to also know what your needs are and to how to advocate for those needs and how to provide those needs. So, I mean, as Barbara said, 30 years ago, it was really just, a doctor treating a disease and not looking at survivors as people. And through kinds of forums like this and the other educational resources that are now on the internet and now provided, it's important that it is a two-way street and that we educate and empower you, but that we also educate and empower providers so they are responsive to your needs.
I don't mean to belabor the point. I just want to say lack of education and communication on her part with her healthcare providers was not one of the issues, and those are important points. But she definitely had a clear knowledge on how to communicate. She had a very strong support base. She had a support group and a support system behind her. So any loophole she may have overlooked, she definitely had people looking out for her. And that's one of the benefits of belonging to a support group and being educated by that group. So I appreciate it.
I'm going to continue on with just a slight shift to see if I can bring us back to what else do we need to know? And I thank the comments so far. What else do we need to know? Educate us, dialogue with us, the so-called healthcare professionals, including our physician colleagues who are very much with us in the audience. What about cancer survivorship do you feel needs to be addressed? Maybe it was you didn't feel strongly that it was being addressed for you. Is there something about cancer survivorship you really want to pinpoint our attention to? Yes. Right over there. There's this wonderful little standing place waiting for you right over there. Thank you.
My question is
Come closer.
closer.
Really closer.
Oh, I'm sorry. My name is Marcia. One of the things the biggest things that need to be addressed is when the patient is going through all of the treatments and they're presented with the options. They've gone through all the treatments. Now they're left with the results. What they have left of their life after they've done everything the doctors have advised. The lack of information that the patient and the care providers are provided with up front. Making that choice. Is it worth it to go through the treatments or to deal with the cancer that's been diagnosed? Has to be the hardest and the most difficult thing to face. And when you look at it at the outset or at the end of it, and you go, gee, everything that they've gone through and they've endured, was it worth it? Did they gain time, but their quality of life was so reduced that you really question? Had they been given more information up front, would they have made the same choices? I guess that's my question.
I'll let the panel members self-choose to answer. I just want to make sure that I understood what you were saying.
I scrambled a little bit.
No, I think you were very clear. Are you saying that you're thinking that people are not always given as much information as they may have needed to help them be a better participant in deciding whether they would or wouldn't proceed with certain of the treatment options? I thought I heard that as the question. Yeah. Dr. Cunningham wants to take that.
Yeah, so I mean, I can everybody hear me okay? I don't know if this isn't on, I don't think.
Here's mine.
Yeah, okay. Thank you. So I think that's actually a really critical issue in terms of helping patients to make decisions. And one of the reasons why we need, to understand not only what the therapeutic outcomes are going to be, but what the quality of life outcomes are going to be. So quality of life studies, which really look at what are the effects of these different treatments, have become really, really important in cancer since the early 1990s. And the purpose of that is really to provide patients with the information that they need to make those decisions. And I think that from a survivor perspective, that's one of the key reasons why we're looking at what happens to survivors long term, because historically people used to just say, well, they survived cancer. Okay, so what's the big deal? It's what else do we have to worry about? They survived. But the issue is, how do people survive and what's the quality of their life? And a lot of our focus in caring for survivors now is in how can we enhance the quality of their lives. So looking at the physical issues that I talked about early on, it's a little bit scary to hear some of those things, but the point of us knowing those things is so that we can help to enhance wellness, to ensure that people exercise, to promote healthy behaviors in this group so that we can really maximize health in this group of behaviors. And I thought it was really illustrated beautifully in the story, that we heard from Donna Lynn, because that is the focus of survivor care, to not only enhance the quantity of life, but really the quality of life, because what makes life worth living for people? I mean, what's the point of living if you're going to be so debilitated by toxicity? I mean, it's an individual choice, but a lot of people, I think, would like to be able to weigh out the risks and benefits before they make those choices. So that's a critical point.
If I could add a little bit to that too, I think it goes back to value questions. Again, what I was talking about with spirituality. Often when I see oncologists, some of them actually will engage with a person where you might be able to say what it is that you value in terms of weighing those treatments, so that when the person who is ill is able to articulate what's of most importance to them, and the doctor knows that, sometimes there's this great interaction where there can be a real shaped conversation in response to what the values are. What I think sometimes now, I don't think you're asking about this, but I see a lot of people for bone marrow transplants who are, when they get diagnosed, so this is an extreme kind of situation, but when they're diagnosed, if they choose not to have anything done, some of those people, considering with their cytogenetics, would actually die in several weeks if they don't choose some kind of treatment. So that's that's pretty extreme. But then if that person comes in after some chemo for a bone marrow transplant, sometimes the things you're talking about, what is lost in terms of gaining more time. Let's just say it's a person who values being outside, who's been outside maybe all of their lives. You put them in a room for 4 to 6 weeks in isolation, but then they get graft versus host or other complications, 2-3 months in the hospital, and maybe more than that. That person, you can see them lose the will to live, because what they value the most, even everyone's encouraging them, but something vital to life, their life, and no one can say they're going to get that back at some point. So I don't know if it's off the topic, but I think it does require that we know, again, what's important to us, and we can say that to the professionals so that we can somehow see if there's some better way to gauge if this treatment is worth doing. I see a lot of people who will choose treatment.
I noticed as you were talking and as you asked your question that Donna Lynn was shaking her head, and so I'm thinking you might have something to share at this moment.
You're very intuitive, Dr. Barber. Thank you. I'm very careful because I'm obviously riding the fence. I've walked the walk as a patient, and I have a very high regard and deep gratitude for the journey that I've traveled with my professionals. I think it's very evident here that the panelists that are in this room are also deeply committed to their patients and to ensuring that their patients have a high level of care and concern. I do feel as a patient that there are responsibilities that we have in developing relationships with our professionals. And I always considered myself to be an assertive patient, a knowledgeable patient. I made it a concerted effort to read books on how doctors think, and I read medical anthologies about how doctors and nurses have relationships in development with their patients. I made a concerted effort to try to get in their shoes so that I understood how and what they were dealing with in trying to deliver quality care to me. I also have a background in the health insurance industry, so I was very much in tune to the managed care pressures that they were under, to the realities of their workplace pressures, to some of the administrative pressures that they had. And so I always came to my healthcare providers with perhaps a more realistic view. I don't want to be too harsh in my phraseology, but I think it's very important for all patients to realize that we do have the best system in the world. It may not be perfect. There are certainly limitations, but there's a lot that we can do as empowered patients to help our professionals provide the best quality care to us as individuals if we emote that effectively and we respect that they are doing the best that they can with the tools that they have and the support that they have. So I encourage you all to continue to express yourselves in ways that are appropriate for you in the journey that you've had, but I think it's also very important to honor what these professionals are here trying to do for you tonight and continue to do in their careers.
Oh gosh, I didn't know I was just fishing for a compliment there, Donna Lynn.
It works both ways, Barbara.
And by the way, Donna Lynn wasn't kidding when she said that she wanted to be able to wear certain clothing. I'm standing here watching the strap marks for her bathing suit. So I know you were telling us the absolute truth. You took advantage of that.
Thank you for pointing that out,
Other
Barbara.
questions? Other questions? Yes. And
That's okay. I want to follow up to what was said. let me first say that the physicians that treated my husband, I feel, gave him the best information that they understood at the time.
Yeah.
He came to them with a very complicated nasopharyngeal cancer. It was stage 4C when it was diagnosed. He had already lost motion in his jaw. He had no movement in his jaw. He had already dropped 83 pounds. So he was basically walking in as a skeleton. Now, he had been under the care of professionals for the past 6 months just trying to determine what was going on. Given all of that, he went through, that's okay, it's not going anywhere. He went through grueling treatments. Today, he is on a feeding tube. He is on every 3 to 4 hours pain meds and liquid nutrition. Can't speak, can't hold his head erect. He's still mobile. He cannot regulate his own body temperature. So there are a lot of issues that he is facing today that we as a family are facing. And I think if he had to do it over, again, he may question with what he's left. He's basically trapped in his body. He was a very healthy man. He was 185 pounds, 6 feet. He was at a very physical job. And he never had any heart disease, nothing. He ate well, took care of himself.
Right.
So to be left with that, his quality of life has sorely suffered. So has his children by watching that. Again, just having the information, I believe in patient education. I got a crash course when my husband was diagnosed in just trying to understand what we were facing, what he was facing. And since he really couldn't speak, I was his voice and still am.
Right.
He is now in hospice care at home only because he's refused any further treatments. It's not going to help him. And the effects that they're offering, or the treatments such as a tracheostomy, he can't even be tested. So we don't even know if the treatments were successful. But what they suggested for him to have done would more than likely have killed him. And the same answer that I was given from the radiation oncologist after a year of being diagnosed and treated was he was 4C, it's a year later, and he's still alive. Was very harsh reality. He is. So I absolutely understand. I have done every bit of education that's available. Mm-hmm. I've read the stories, the case stories on bone marrow transplants. I've read the medical books. I've scoured the medical libraries. But even having all that information, while it's helping me to get him through every day and helping my family to get through this, mm-hmm. I feel like the access to that information is not as easily obtainable unless you work in a medical setting. To the average mm-hmm. citizen, mm-hmm. you have to really go inside a medical library to be able to even have access. And that's just not really there.
Let me take that question, if you will, and the comment, because it's so poignant, a story that you tell, that I think it's almost impossible to respond from the podium in a way that honors the courage that you just showed in telling this at the heart story. I think the theme that I so pulled out of that once I tried to get past the emotion mm-hmm. of hearing you speak, the theme that I pulled out of that is that we health professionals need to question ourselves. Are we giving the patient, in layman's terms, the very best understanding that we can of how severe the consequences can be if we choose the left-handed or the right-handed option? And to try as best we can to check did that person really understand at the cellular level what it is that we were trying to share about those two options and the potential consequences of either of those options? For me, at the level of going forward for the state of New Jersey, that's the question, that the challenge that I took away for ourselves. Have I missed the challenge from any of the rest of our healthcare professionals' points of view?
I think it's that. In addition, when I heard you tell the story, it's the story of a trauma. It's this. You nod your head. It's an ongoing trauma, and you alluded to post-traumatic stress disorder and what you were saying, and I see this over and over and over, that all the education and information in the world can still register as traumatic because it's overwhelming. You don't know at that particular point. You may be told all the facts, but you haven't lived into it yet. So I think in a sense it is a veil between those on one side, we're doing the best we can, but we're not living it really. And then on the other side, just being completely overwhelmed and doing the best that you can, covering all of the bases, but living with daily losses. So, I mean, I don't know what to say to you.
Brought very important points. Sorry. Each of you brought extremely important points, every one of you, from every level to 2 years without sex, being a normal, healthy female. And that's the reality of it. And it's at a point where everything is painful to him, so nothing intimate is even an option. I mean, even from, you try the massages, you try the hugs, just to make him the least bit comfortable. And even that at some point becomes painful. As you're mentioning, as each of you were mentioning, the spiritual side of it, we try to look at the smallest benefit. You look at the financial issues, going full-time from being at home and working from home to full-time outside of the home to just have health benefits, where you're paying $800 a month just to maintain those benefits. Each one of them affects you. And I think that's what most everybody is here. We're all looking for answers. We're all looking for a way to help, whether we're the patient or whether we're a caregiver. We're all looking for answers. And I think the biggest thing, it was 6 months before he was diagnosed. And in 6 months, he went from being able to eat and speak and talk and work to without speech, without food. You almost wish that there was better recognition or maybe a better understanding by the primary care providers or the dentists or the people who were seeing him all that time and didn't hear the symptoms or didn't understand where to put them.
So I hear a second theme.
There's a lot of themes.
Well, a second theme
There's a lot
before
of
I
themes.
move on. I didn't forget you, by the way.
I'm sorry, I'm
didn't
kind of
forget you.
hogging the floor.
I do hear a second theme, and that is to challenge us to make sure that the full range of professionals who have to understand bringing issues forward to diagnosis as quickly as possible is certainly a part of the whole cancer continuum.
That works.
I hear. And I promise you, can I get you to the microphone? Is it possible? Oh, we're going to get you to again show them that there are a lot of folks here who have some thoughts about survivorship.
My name is Claire Dixon. I'm battling colon cancer. What I missed most was at the end of the surgeries and chemotherapies, when I went for my meeting with the oncologist and I asked for a survivorship plan, there was none. The institute in which I was treated had none. And I felt I was in free fall. I was the most depleted in terms of strength, ability to advocate for myself. And there was nothing for me. What I needed was a coordinated, structured survivorship plan from the institute in which I was treated.
So, yeah. Yeah. Thank you. Thank you very much for that comment. I just want to address that. So the concept of looking at survivorship as a distinct phase of cancer care is relatively recent. And you heard several people now refer to the report that came out from the Institute of Medicine, and Barbara talked about the name Lost in Transition. Couldn't be truer. What we have heard from patients is exactly what we just heard, that once patients complete their cancer treatment, many times they feel as if they have fallen off the scanner. So they're in this very, very tight, communication with their providers. They're coming in for systematic treatments that are cyclical in nature. So they're in constant contact with the healthcare system, and then all of a sudden, boom, they're released of they're finished with their therapeutic plan. The IOM report specified that all patients who undergo cancer treatment should receive what they're calling a survivor care plan or a treatment summary. What's included in this document should be a summary of the type of treatment that you received. One of the reasons that is so important is because that treatment summary is actually what will define or predict your risk for long-term effects and late effects. In addition to that survivor care plan should include information about what kind of surveillance you need, when you need to follow up for screening. Again, that would depend on the individual type of cancer, what type of health maintenance plan you should have, and that document should be given to both you and it should be sent to your provider in primary care. So again, one of the big issues that we hear about from patients is that when they transition from one provider to another, there's this, what they call a quality chasm. It's like they're millions of miles apart and there's no connection between the two of them. They're very disconnected. So it's important to try to make sure that information flows to other providers who are involved. Yes?
If I could follow up on that? Uh-huh. The form you're mentioning is readily available on the internet,
Right,
which I got by myself and took back to my oncologist. What we need is more than that. We need each of the things that you're talking about, each of the areas, as opposed to a form on which I list the chemotherapy treatments I had and who I should see and when. I need more. Absolutely. I need all of the areas covered in a way that I have some routine and structure where that's offered to me, so that all of the personal issues could be explored, as well as the general issues with which we all deal.
Right. I appreciate that comment, and actually we'll go back and look at ours, because hearing some of the comments tonight it was very informative in terms of some additional information we could be providing to people. So thank you for that comment.
Absolutely.
Can I just ask one question? Where did you get it on the internet? Did you get it on the ASCO site? Do you know what site you got it from?
It's been a year and a half or so.
Okay.
No, I don't. But
American
I know
Society
if
of Clinical
you
Oncology?
type in cancer survivorship treatment plan, it'll come up.
Okay.
It's
Great.
available at places like the Mayo Clinic, et cetera.
Yeah. Thank you.
Can I just comment? Well, I mean, one of the things that survivorship organizations, and a lot are represented here today, the National Coalition for Cancer Survivorship, the wellness community, cancer care, have all been fighting to have much more routine post-treatment care, including these survivorship plans that were in the Lost in Transition report, but that the plans are also multidisciplinary, that are not simply your medical needs when you need, scans and other kinds of treatment and follow-up care, but also dealing with psychosocial issues, employment, insurance, finances, all the things that cancer affects. Those don't stop, begin when you're diagnosed and stop the day you stop your primary treatment. They're, in some ways, they can be with you for your whole life. So we're trying to make that kind of follow-up care very holistic and multidisciplinary.
And if can I just add, some of these plans are in transition. There's a lot we still don't know. As Regina pointed out, the whole idea of survivorship plans is relatively new. And I know no one wants to hear this, but there's a lot of gray areas in medicine. There's a lot. It's not always black and white, and we struggle with this. But we just don't always know, if we do this, what's going to be the outcome in your husband. We don't always know this, and we struggle with that. The survivorship plans are in transition. There's a lot of research that we need to do to know what should be the frequency of follow-up. We don't know the answers yet. Just keep in mind.
Yes, we've promised a long time. Yes, over here.
Hello. Thank you for the opportunity to speak. I want to make one short comment on Deborah's issue that she had. She was up here earlier. I know I heard someone say, what you see depends on where you're standing. And what she described, I see all the time. I'm a 9-year breast cancer survivor, and I had a support group. So there's so many issues and problems like that, stumbling blocks that come up in people's way. And it seems like sometimes I'm the only person that hears all these problems because nobody else hears them. But there's a lot of things out there that happens to people, not only at end of life, but as they're traveling through the medical field. I want to make the comment on someone who had mentioned that a cancer patient has the responsibility or to self-advocate for yourself. That's hard to do. That's like putting it back on the victim. We are the victims. I advocate for people all the time, but when you're going through, it's hard. And the only thing I would suggest call to action is when you're looking at somebody face to face and you just told them they had cancer and they don't have any questions, that's a clue. Either stop and tell them to go home and bring somebody back or something. Try to read the faces of the person that's looking at you because sometimes they don't understand. Thank you.
Thank you.
You know what? I want to make sure that I did not communicate that you are wholly responsible for the information that you receive. There are, in terms of, I think it's most beneficial for people to have advocacy skills. I see my role as a nurse, and when I educate nursing students, I think their role is to help family members and individuals with all types of diseases to learn to advocate for themselves. But certainly when people are facing a diagnosis or going through very emotional and physical ordeal with cancer or any other illness, that very often it's not possible for them to advocate for themselves. So their role of having an advocate, having a family member, a friend, a colleague. I could remember when, I don't speak a lot about my husband's diagnosis many, many years ago with lymphoma, but it was perfectly clear when he was diagnosed that I did not hear one thing the oncologist said. My anxiety level was so high, I literally did not hear anything. So I could not advocate for him at that point. I needed to come back. I literally needed to say to that oncologist, my head is spinning. I'm not hearing one thing you're saying. Please say it again. I need to sift through this. So no, you are not solely responsible for your health care, but you need to get as much help as possible. And whatever resources you can use to help you, you absolutely need to have that. So please, if I communicated in any way that you are responsible for getting that information yourself, that was not what I meant. My apologies.
Yeah, as a survivor, I would also like to reiterate and support that comment. In no way were my earlier comments meant to minimize anyone's experience or to suggest that anyone in the audience was not a thorough researcher or advocate in their own journey. But what I would like to say as a patient and a survivor who did have the resources available is pick up the phone and call these resources that are free and just willing and waiting for your call. The American Cancer Society, amazing amounts of information. The wellness community, a grassroots organization, yoga instruction, food and nutrition classes ongoing, free psychosocial counseling, social workers 24/7. I would call them on the phone. I would have a phone call back in 5 minutes. You know, just as an anonymous person. Team Survivor Tri-State that I mentioned as an athlete. Free fitness programs, free spinning, free yoga, free meditation, free seminars on coaching seminars, how to redirect your life, how to stay plugged in, how to meditate, how to utilize alternative medicines. The resources are there, and that's why I beg you to please utilize the panelists here, utilize the free resources through the nonprofits in your community. Pick up the phone and call the Chamber of Commerce and say, hey, I need to know who are the nonprofits on your roster, participation, membership list that will support me in my journey. I'm alone, I'm scared, I'm unsupported. The resources are there. You have to pick up the phone and advocate for yourself and be resourceful before you're leveled, as I was with chemo, radiation, cyberknife, etc. Call on your friends. I need help. I don't need a meal. I don't need another bouquet of flowers. I need you to research this aspect of my treatment or this aspect of my disease. Can you help me? You'll be amazed.
One of the limitations we have up here is we can really only give you very general bits of information and general advice. Cancer is a very personal disease, and what may work for one person, somebody else may need a totally different answer.
Exactly.
The key is to express what your personal needs are. If you can advocate for yourself, that's a wonderful thing. If not, then reach out to family, to friends, to coworkers, to professionals, to all the nonprofits that you can find online. Reach out to whoever you feel comfortable reaching out to for the information that you need personally. And there is no right or wrong way to do it. It's whatever works for you.
Just to
Point well
build,
taken.
I'm sorry. I'm sorry.
Go ahead. I just want to make
Just
sure I
to-
get a couple of more people who
Just
really...
to build in quickly, one thing that I'm noticing is, and maybe it's certainly not intentional, but one thing I find as a chaplain is that there are a certain number of people who can't put words to their experience. So in some sense, what I notice about myself is that I'm prejudiced, in a sense, for people who express themselves verbally. And maybe we all are, because of our roles, professional roles, and how we've been trained and educated. I'm not saying at all that there's not a lot of feeling and understanding inside each person about what they're going through, but not every person can put words to that. We are biased to your expressing yourself. I will say I just noticed that in my own setting and where I am. The person who can do a good job at that gets heard. So just another way to think about advocacy, that those may not be the skills you have, or you may be demoralized, it's like we've been talking about. There's all kinds of things that happen that make it difficult for some people to articulate in words. So I guess what I would end up saying is that there is a way to communicate, but sometimes it's on us to find what that way is.
I hear. Thank you. Thanks for that addition. Yes, we did promise you. Are you coming to the microphone for us? To the real microphone?
Okay, I'll go there.
He's coming to the real microphone.
Oh, there was somebody there. I'm sorry.
Okay. It's just that he's been waiting for a long time, and I was taught this like orderliness thing from my mother. I think 1, and then comes 2, and then comes 3, and his hand has been up a long time.
Well, thank you. I'm a 6-year survivor now. I was diagnosed in '02 with multiple myeloma. I've had 2 stem cell transplants here, and I also had 4 intensive chemos. 28 months ago, I was like, I might make it or I might not, so I got the opportunity to try a trial drug. Now it's 28 months since I've had chemotherapy, and I feel great, and I don't know what else I could say. But hearing all these things about treatment, I've had so many fellow patients that are deceased now that have been in programs with me. I spoke at their funerals, sorry to say. But the thing is, the end-of-life thing that came up as a subject, and a non-caring doctor, I always say to everybody that I meet, if you don't think you're getting through to your doctor, or he's not getting through to you, that's your fault. Get another doctor. These people, if you think the doctor isn't on board with what you want, I've been fortunate enough to be led by doctors that kept on striving to stop my cancer. When I started in '02, I had 98% cancer in my bone marrow and 95 in my bones. And right now, I don't need chemo. Thank you for your time, and I'd just like to say I appreciate all the medical staff, what they have to say, and it's very moving for me to speak from where I'm at.
Thank you. Thank you. And now, yes, thank you for waiting. I appreciate it.
I guess I'm a little short for this. My name is Rosemary. Actually, I'm a 2-year survivor today with CML, and I also have endometrial. But cancer is changing, and people are taking oral medications now. I mean, I'll be probably taking mine forever. And that's something that I don't really see that much. I don't see... It's geared towards people having systemic chemotherapy, intravenous, and then ending. And I think we need to start focusing on the changes in the way chemotherapies are more going to become oral, and the whole implications that brings up.
Dr. Cunningham?
Just briefly, I think that's actually a really important point. So, as she mentioned, the number of oral chemotherapy drugs that are currently under development and those that have been released in the past couple of years have really increased substantially. So that's a wonderful benefit in many respects, but with it there are a number of issues that really need to be explored. So, and some of these things we're just really learning about now. So how do we make sure that, the medications are taken correctly? This sort of really shifts the responsibility from you coming into the healthcare where you're going to get the IV chemotherapy to you taking your chemotherapy medications at home by yourself. So there are a lot of complex issues surrounding oral drugs, and definitely that's an area of research. Interestingly enough, I just returned from a major national meeting, the Oncology Nursing Society, and I was very pleased to see that 2 very, very large research grants were actually awarded to look particularly at issues that patients are experiencing when they're on oral therapies. These were the 2 most substantial grants that were awarded by the ONS. So people are looking into that issue. So,
Thank you.
Yeah, thanks.
Thank you. Next question coming up.
My name is Nancy, and I'm a 2-time breast cancer survivor, but I work in the breast cancer community. And as I was listening, I was listening to the panel, and Barbara invited us all to bring our concerns and our questions to the medical community. And obviously this is a well-educated, empowered audience, as is the panel, but Dorothy, my colleague over here, raised a point that made me realize that I think there are many of us here in the breast cancer community who advocate for people who can't advocate for themselves. And while I understand that there's lots of resources out there. I took advantage of all of them myself. Having resources available doesn't mean that people can really access them. There's a population out there of people who can't, and we in the community are their advocates and we're their voices. So my point to the medical community, obviously not to this panel because you're in tune and you understand, and maybe not to the medical professionals in this audience, but if you're bringing this to a wider audience, is when you're dealing with patients is don't assume that they have a base of knowledge that they may not have. Don't tell them something and assume that they know what the next step is or that they know what the previous step is. There are a lot of people who hear what you're saying and they don't know what they need to know before or after, what comes after, what the next steps are. So for the medical community, if you can treat people as individuals and understand that they may not come empowered with information and they may not come empowered with knowledge, so you have to treat everybody differently and really try to understand who you're dealing with, what their background is, and what their level of information coming into it is.
Thank you.
I just want to convey something that I heard from the audience, and we've heard a lot of different websites and places for people to go. And a person in the audience said, but how do they find those? If there's one place or 2 places that is easy to find and start the search, where would they go?
You're asking for each of these folks in their specialty domain where they would send the folks?
No, not so that there
General.
are 6 or 8. If someone wants to start, where can they go with one quick phone call web?
Yeah. Cancer.gov is great. You're going to get a few of them. Okay, let's hear a couple more. ASCO.org.
American Cancer Society.
1-800-ACS-2345.
Mention that. Yeah, internet.
That's a good point.
Mention that.
That's a good one.
Okay, I'll live it.
Anne Marie's going to listen, but let me hear. Of course, by all means. Thank you.
My name is Jean Barber Little. I'm a 20-year survivor of one and 17-year on the other one. I didn't go through treatments. I didn't go through chemo. I didn't go through radiation or nothing. But when I hear somebody get sick or they die, it bothers me. But I don't even know how to work a computer myself. But I went to a research program last year, and the scientists had to help me with the computer. I still don't understand what I'm doing on a computer. That's why I'm saying everybody don't understand computers. And I'm one of them.
I hear you, and thank you for that. And that's why when Anne Marie Hill puts this report together, she's going to put things that are also phone numbers that we all understood before we understood how to tap our fingers across the computer. We understood that. So we'll add those to the list as well.
Barbara, if you don't know that the commission publishes this book as best we can, and we try to update it with the most recent information that we can. And I hear what you're saying. So we try as best as possible to include all the websites and all the resources and phone numbers that we can in New Jersey and nationally in this book. And
Tell them the name of the book.
it's a resource book for cancer patients in New Jersey. So we would appreciate your help if you do know of sites or do know of resources that are available that aren't listed in this book. We try to include everyone, but of course we miss them. If you do have information that I can use to put in this book, I would really, really appreciate it.
That book is free, and we'll give you as many as you want if you're part of an organization. Just grab
Or even if you're an individual, you'll give them. Yes, that was Anne Marie Hill, Executive Director of New Jersey Commission on Cancer Research. Her worthy colleague, Michael Tolino, giving those two pieces of information.